Hello and welcome to this important discussion about CLL active monitoring. You've been all working very hard on a call to action for CLL patients on active monitoring. Thank you so much for being here. My name is Jan Geissler. I'm the CEO of Advocates. I've been a CML patient for 24 years, and I'm really attached to this topic because we need to make sure that patients are monitored and supported in that critical phase after diagnosis. So thank you so much for being here today. First of all, introductions. Can you please introduce yourself? Tell me what your connection to CLL is and who you are.
I'm Dr. Christina Karamanidou. I am a health psychologist and a researcher at the Institute of Applied Biosciences in Thessaloniki, Greece.
Wonderful. Thank you for joining us.
I'm Lydia Scarfo. I'm a hematologist working at San Raffaele Hospital in Milano, Italy. My main research and clinical interest is CLL since a long time.
Thank you so much, Lydia. Welcome.
Hello, I'm Jana Pelouchova, and I'm a CML patient for more than 2 decades. And after running a CML-focused patient organization for about 8 years, we decided to expand our activities to all types of leukemias. I became one of the founding members of the CLL Advocates Network, and I'm on the steering committee of this network.
Thank you so much for being here as a patient and patient advocate. Thank you so much.
Hi, and I'm Peter Haggert. I'm the chair of CLL Advocates Network, and I've just been this chair for shortly under a year. And I'm also vice chair of CLL Canada. I am as well an active monitoring patient for 6 years now, thankfully, and want to be that way a long time.
As you know, chronic lymphocytic leukemia, being the most frequent leukemia in the Western world, follows generally an indolent course. So the majority of patients do not require treatment at the time of initial diagnosis. And there is a period of time when we follow them and try to discuss with them issues that are not entirely related with the treatment management, because some of these patients may actually never require treatment. So active monitoring is a crucial phase that the vast majority of patients will undergo, and it's very important, I believe, to discuss with them and explain, because it's something that is not very intuitive for the majority of people.
So why a call to action then, Jana? Why did you actually engage with the whole group about a call to action and active monitoring? Where's the issue? Why did you get involved?
I was even surprised that the patients who started coming to our lessons and engaging with the community were from both sides, both patients on active monitoring and also patients on treatment. So that was a proof for me that both of these groups of people, they need some empowerment. They are keen to learn both about the disease, the treatment options. So somehow I saw that there's challenges even for patients who in the end might never need treatment, but still they need to be empowered.
And Peter, I mean, you've been on active monitoring for quite a while, so where's the issue? Why is empowerment needed from your perspective?
Active monitoring is very different for a cancer patient because, you know, you look at me and you may not know that I have cancer. And so sometimes it's hard for people to believe. So that's a frustration and a mental challenge for the patient themselves. And I think that there's information that can help them through those active monitoring years and help them keep everything in the right perspective for themselves. And I think it's necessary that as soon as they're diagnosed, they get some support right away so they can negotiate what they have to deal with. So it's always going to be an issue. Every new patient is going to need the support.
And I mean, we've had a couple of workshops last year in September and also in January this year, where we discussed about different needs of the community. So what, from your perspective, from your both perspective, what stood out in the report? What was really crucial that made you think, yeah, we really need a call to action on these things?
For me as a physician, it was extremely relevant to understand that we have to improve our communication. I mean, it's crucial to communicate in the right way with the patient, and active monitoring is a very complicated concept to explain. So I just say that a proper training, role-playing, this is something we definitely need as physicians in order to improve our communication skills.
So training is very important, was one of the three main unmet needs. And a topic that came up a lot was also about multidisciplinary teams and having actually different disciplines in medicine actually working together. So what's your perspective on that?
Yeah, definitely. This is something I feel very passionate about. I think definitely the healthcare team needs to include specialist nurses, obviously physicians, clinicians, psychologists, even social workers, or whatever else is needed at that point in time for the patient. But mental health is ignored sometimes, and in some parts of the world there isn't the feasibility of having somebody, a mental health professional on board, and I think that's really important. Or it's a taboo to ask for a mental health professional.
Yeah, unfortunately, I mean, mental health and strain is a lot of, and also stigma sometimes is a big issue. So Peter, I mean, you've been living with active monitoring for quite a while. If you think about the call to action, what resonated most to you from a personal level?
Sure, so one of the first challenges is finding good information, finding accurate information, information that works for you. You know, if the day I was diagnosed, it wasn't a diagnosis, it was just my general practitioner saying, oh, I think you have leukemia. I'll send you to a specialist in 2 months. So that gave me 2 months of uncertainty.
Oh, yeah.
So you go to the web to look for information, and some of it's relevant, some of it's not. So it's very important to have information that's relevant to you with your circumstance, given your culture, your country, the availability of information within your area.
Do you have any perspective on that from your side, Christina?
Definitely. One of our qualitative studies was only on patients on active monitoring, and it was published. It was called The Looming Cancer, and the reason it was called The Looming Cancer is because patients do feel that there is a shadow over their heads, like something is going to happen, but they don't know when and they don't know how, and this is causing great anxiety. And also it's the paradox of having cancer and being told to just go home and do nothing, and this causes a lot of cognitive dissonance in patients, and that's definitely absolutely crucial to frame in the right way.
Thank you so much. I'd like to actually zoom in on one of the first of the three topics of the Call to Action report, and Jana was alluding to that already a bit, doctor-patient communication, because of course this is super important in that phase. There's nothing to treat, but there's a lot to talk about. So where do you think, from a healthcare professional perspective, where are these kind of breakpoints in communication, where are the challenges for both sides to talk to each other in that phase?
I would say one of the crucial issues in the healthcare professional and patient communication is related with the time, because we are all short of time. The clinic is full of patients who require our attention, and sometimes I think that most healthcare professionals feel like the patient with CLL on active monitoring are not that relevant, meaning that they do not have urgent issues that need to be managed. So they sometimes overlook the relevance of a good communication with the patient. This time is needed in order to discuss in details what happened between the two visits and especially at the first appointment when you have to explain, as Christina mentioned, that the patient has a diagnosis of leukemia that everybody associates with a life-threatening disease that requires immediate intervention, and then there is this physician telling me you don't need any treatment. And in this regard, I think we made a great improvement by switching from the previous term that was watch and wait, and as Christina mentioned, it reminds like we are waiting for something bad is going to happen, to active monitoring. That it means that we are taking care of the patient even though we are not administering CLL-directed treatment.
You're bringing a very important point, because this was actually a very strong call from the community, which felt, I understand, watch and wait is not the term that we want to use. So what was your perspective in these workshops, and what ended up then as a recommendation in the call to action to both of you?
So I think when it comes to the term of active monitoring, we have sensors now to talk about our heart rates and all these other things when we do running. We're actively monitoring our heart rates. This is the same kind of an active monitoring. There's nothing to say that there's going to be anything bad. I've been through 6 years of an appointment every 6 months now. I don't go in thinking the worst, but I go in thinking of it as just monitoring, as opposed to waiting for that one time it's going to be really bad. So we have to change that perception from the beginning. When that patient goes to the doctor as well, and as soon as that doctor says the cancer word or confirms a cancer word, we go deaf. We go deaf to all the wonderful description or information that's provided, because our brain starts talking about those what if, well, who do I have to, we start thinking about other horrible questions no matter what you say sometimes. So that's a consideration in that zone too. And all these things have to be incorporated when it comes to putting together a plan for better communication.
Yeah, I can relate to that, and I think it came up very strongly in the report also that what you were mentioning, Peter, about the cancer word. And that's very difficult in CLL, because it is, of course, a cancer, because it is a difficult thing, as people perceive cancer as something else than what they're actually put in when you put them on active monitoring and discuss that kind of phase with you. So what's your perspective on that kind of doctor-patient communication on that?
So as physician, I understand that telling a patient that he or she is diagnosed with leukemia, and I'm not proposing any intervention, it sounds like a death sentence. But what I'm trying to explain during our first consultation is that this is actually in their best interest. So the choice of active monitoring is in the best interest of the patient, and we will try to extend this period as long as possible, provided that the patient is doing well.
You're explaining this extremely well, Lydia, but I know that very often that doesn't happen out there in the field. And we have the topic of doctor-patient communication. And probably over to you both. Usually you need to combine kind of emotional empathy, support, and so on in that first consultation to take away the fear. At the same time, you need to deliver something very technical. So what is your recommendation? What came out of the report? How to deal with that kind of gap between very technical information about CLL and active monitoring and emotional support?
Well, I would say from the perspective of the patient organizations, they have to provide much more information in whatever format of materials, printed, videos, to focus on this issue, because even in general, the communication between doctor and patient for some patients is absolutely not enough. They would need much more, double the time, triple the time, and of course, we understand pragmatically that this is not feasible. So this is a reason, even prior to involving the CLL patients, even in the CML field, to make some educational programs that would enable a communication between patients and hematologists in a more friendly atmosphere, without the white clothes and over coffee, to discuss these things in depth, to allow the patients for further questions for which there's no time in the office. Also to involve the caregivers, who even sometimes don't accompany the patient for the checkups. So they are only relying on the, so to say, interpretation, what the patient says. What did the doctor say? Nothing. That's the usual scheme. So then, to give also the family relatives a chance to hear the doctor, even to ask their questions, how to better support the patient. And as I see, as I mentioned before, the CLL patients in the active monitoring period, they understand this program very well from the beginning. This is our chance to extend the time which is spent in the doctor's office, and here is the place to learn more.
If we have patients who know more, who learn more, then when they do see a doctor, they don't have to ask the very basic of questions. They can spend time with the doctor asking better questions where the doctor's the best suited to answer those questions. And I can tell you, we do a conference every year, a CLL Horizons conference for advocates. And the top-rated session at last year's conference was a mock-up of a doctor-patient interview. Doctors saw it one way and learned things. Advocates saw it a different way on how to train their patients to speak to doctors. So the patient has to be educated as well so they can be a partner in that conversation.
Doctors can shift their way of communication as well, from closed questions to open questions, just acknowledging the emotional distress that patients might be feeling at this particular stage. Just acknowledging the distress makes them feel validated, and then they can move on to more cognitive tasks, let's say, like absorbing all the new information. But you need to lay down the emotional part first.
So that's super interesting because we're covering different areas. Like you started with the time required to actually get the consultation, which usually let's say the system doesn't really allow because everybody's under pressure, over the language that you use, and also connecting the emotional bits with delivering information, which probably brings us into the next topic of the call to action, which is about delivering information. Because there was a very strong call of improving access to trustworthy information.
And in many countries, when you first leave that doctor's office, you may have a written piece of material, but what you don't have necessarily is a contact. Who can I talk to with my questions in between appointments? And what we find often is the case are doctors, clinicians aren't referring patients to advocacy organizations or other organizations that can help. One of the other issues there is, we can have a booklet or something, but I know in my case, I didn't read the booklet because I was scared stiff. My wife read it cover to cover 3 times, I'm sure, but everyone takes information in different forms these days as well, and they react differently to different forms. So we need to be able to provide that information in the way that it's going to be receivable at the other end by the patient.
And another point to take into consideration is in the modern world we have plenty of information, but I think we should identify trustable, reliable source of information. And this means that we as healthcare professionals should probably provide some reference to the patient in order also to improve their knowledge on the disease. For example, I have frequently a discussion about overall survival related with the disease, and many patients came up, and I don't know where they found this information, that the overall survival of patients with CLL is 10 years. So I try to explain that, of course, we cannot predict the fate of the single individual, but some information is already dated when you read it, because we are definitely improving day by day, year by year, the management of CLL. So the main point in this context is to discuss and explain and provide sources the patient can, after the visit, read on their own and further discuss with the physician. So in an era where Dr. Google first, now the AI are trying to replace the physician, as Peter mentioned, a well-informed patient is probably coming to the visit, asking the right question, and exploit the time with the physician in the best way.
And interestingly, in the call to action, 2 of the 3 points that were actually made in that section were about a scoping review of existing materials, because participants in the workshop said we must look at material we have, because there's a lot out there. It might just not be updated or not available. And I think that was a very strong call. It just needs to be done in the call, after the call to action now. But also about translation update. And I mean, you're from Czech Republic, and what do you think about language? I think you alluded to that a bit earlier on. So what's the issue about language?
Well, I think that, of course, there are patients who know English and who can access on internet reliable material coming from medical resources. But the aim of the organization is to provide information to all, not to leave some patient behind.
I'd probably like to cover another topic that also came up in what you said, is also about health literacy. Because we're often talking about trustworthy information, which you said, but many patients also can't understand the information we're providing. So what's your perspective on health literacy, and how would you want to address that in that phase of CLL patients when they're in active monitoring?
The golden rule for health literacy is really to start at the base of the patient's knowledge. So you start with the real basics. You ask what they know so far, and then you build up the information, the knowledge in a series of meetings, not everything at once. But health literacy is not just about understanding information, it's also about navigating the healthcare system.
And that's exactly also the point. And I mean, you're both leaders of a global network with the CLL Advocates Network. So you have a lot of member organizations in very different parts of the world. And as Christina was just saying, partnership and, let's say, the role of the patient community in that. So I wanted to ask you, what do you think is the role of both a global network as well as your member organization in that area of providing information, because you can't provide it in every language as a global network. So how do you deal with that?
So first off, I think we have to be careful. We can't really deal with the specifics of a certain country. We have to talk more in that general phase of how to approach information, the generality of information, the basic information. And when we do that, sometimes we can do translations and such. So it is hard. We need to be able to give the base information that can be adapted by the country itself and put into into the dialogue the way it works for that population.
Which makes a lot of sense, and actually that's very interesting because it connects 2 of the 3 areas of the call to action, because the second one was really about providing information, and recommendations there was a review of existing materials, making sure they travel, and also thinking about language, literacy, updates, and so on to cover them. But you alluded about the role of patient organizations. And the third recommendation was very strong on finding peer support. And I mean, that's the core, let's say, objective of patient organization, is actually where they come from, usually is peer support. So what's your perspective on the role of peer support in CLL, especially in that area of active monitoring?
Well, I think it needs to be something that will empower the patients to stay in somehow optimistic mood and give them guidances on examples of how people deal with their hobbies, with sporting activities. They have to see other patients, how they're coping, and then they can see, yes, I can manage the same, because physically I can do it.
As a active monitoring patient, I can look at someone like Jana and say, wow, look at how long she's had the disease and she's still thriving. And that's important to my mental balance to understand that, okay, there's no death sentence here. You know, this is just a life sentence and something I have to live with.
Yes.
And what can the patient community do specifically in that area of active monitoring? So where are the gaps and where can the patient community be stronger? Because there was this strong call in the call to action about supporting, let's say, access to peer support and giving peer support in active monitoring.
For us, often they don't know that resources like the resources that groups like ours, they don't even know they exist. And that's the challenge. Because of privacy and such, we can't act. There isn't a list of patients that we can go after, you know. So it's a matter of those people who deal with the patients first, referring them to us as sources of trusted information. That becomes very, very important.
And that's probably an important point, reflecting back to you as healthcare professionals. I mean, what came up in the call to action report was actually that referral often doesn't work. And I'm sure that's not an issue for you, but if you think about all your colleagues, why are patients often not referred to peer support groups and patient organizations, and what could be done about that?
That's a difficult question. I think that from a physician standpoint, probably some of them do not understand how relevant this peer support can be, how crucial, especially even in the first months when you are dealing with the diagnosis, as Peter and Jana mentioned, interacting with people who have been diagnosed years before and are still alive and doing their everyday life activities. This is something I think it might be very relevant. On the other side, I agree that a patient organization, patient advocacy group should coordinate these activities, because it might be that if some patients can spread anxiety instead of reassuring the other patients. So I trust the patient organization, they can provide the appropriate support.
So not increasing fear, but actually taking them with robust information, as you said early on. What's your perspective on that, Christina?
From psychologist perspective, I think in the beginning maybe people are dealing with issues of identity, and from being healthy, the transition to illness, and that is something that takes up all of their, let's say, emotional and sort of physical capacity in a sense, and they need some time before they can actually seek out support. However, I do agree that it has to be coordinated by the patient organizations, because individual pockets may not have the right information, may not have the right way. Also peer support groups, but also the peer-to-peer, one-to-one work really well. And I know in Thessaloniki, in the CLL patient organization, the local one, we coordinated such a program, and it's doing really well.
So do you see any barriers that could be removed in that area of, let's say, getting patients into the peer support that they deserve? Anything else that springs to your mind as an action from the call to action?
Well, I see that the programs that our patient organization designs, and I'm speaking in plural because it's not just the case of my organization, most patient organizations align with clinicians to provide some kind of educational lectures and so on. Once the patients come in, they meet each other, and that's where, without any intervention directly, they can see who is appropriate with their age, who's somehow sympathetic to them, and people on an informal basis can meet up, and they're happy because they found like new friends, you know, and that is very supportive for their situation. It helps also their partners, their family members. So this is how people can get to know each other in a safe environment.
You know, we have to be convincing and we have to be proactive to earn the trust of the clinicians and that community, because wouldn't it be wonderful if one of us can speak to the Society of Hematologists and state our case in front of them, you know? And that often doesn't happen, or doesn't happen near enough. And if we can tell our story and tell it well and show that we are a help and not a hindrance and we're a serious source of information, then I think there can be a win for everybody.
Just to wrap this discussion up, I mean, when people listen to this recording and they actually have the call to action in front of them, what is your recommendation when you think about active monitoring? There were 3 different areas we've discussed. What do you wish them to do? Because we want action on the call to action. So can I start with you, Peter? What is your wish?
I would just say that there's some kind of intervention of information right at the very beginning of the process, right when somebody knows that they've been diagnosed with leukemia, that there are options for more information right away given to them.
Thank you. Jana?
I would wish the patient to feel that his situation is not being underestimated, that he feels himself he's getting the appropriate intervention.
Thank you very much.
For me, the key take-home message would be communication, collaboration, and awareness. So I just say it's important to spread the news, to inform the patients.
Multidisciplinary teams, so we could have patient navigators, clinical psychologists, clinicians and nurses working all together. That would be a wonderful way to start with somebody who has just been diagnosed.
Thank you so much. This has been super interesting, and actually a call to action only works if there is action. So I think your recommendations are well taken. So everyone listening in, I hope they're taking this very serious. Read the report, do things in their sphere of influence to really change the way patients are being treated, or not treated, but monitored and active treatment. Thank you so much for your super contributions. Thank you so much.
Thank you.
Thank you.